Good morning, I'm Jessica Lovell. Welcome to the Morning Medical Update. Too many men ignore their own health. Today, we have assembled a great panel of men's health experts to talk about some, frankly, sensitive topics. We'll ask what we could do to help men take better care of themselves, and how does that care change as men get older. But first, let's get to our morning rounds on this Monday morning. The nationwide shortage of 14 cancer drugs continues with the most critical shortage of two medications, cisplatin and carboplatin. Physician-in-chief for the University of Kansas Cancer Center, Dr. Jeff Holzberlein, joins us to update us on how the Cancer Center is managing this shortage for its patients. Good morning, how are you?
Good, thank you.
Good to have you. Okay, so first tell us which cancer patients typically rely on cisplatin and carboplatin.
So cisplatin and carboplatin are really very commonly used drugs for the treatment of a variety of cancers. The most commonly treated cancers would be lung cancer, ovarian cancer, testicular cancer are the primary cancers.
So some hospitals are needing to ration medicine, but how is the health system and the Cancer Center handling the shortage for its patients?
Yeah, so this is again a nationwide shortage, but the University of Kansas Cancer Center has been able to manage this so far, primarily through just really great work with our pharmacy team and making sure that we're using those medications appropriately, and again, working very hard to ensure adequate supplies of those two drugs.
And if patients have a concern about something, should they be asking their, people have concerns about something, they dive into Google. What should they be asking their physicians?
Yeah, so I think it is obviously they have a concern that they should contact their physician and discuss those concerns with their patient or with their doctor. Of course, there are also some national websites. The American Society for Clinical Oncology has a Twitter feed, and they regularly update that Twitter feed regarding the drug shortages. So I also direct patients there. How
long do you think this is going to last, Dr. Holzberlein?
Yeah, so, the problem with drug shortages, this isn't a new problem. We've been dealing with this, particularly for generic medications, for the last several decades. We're very hopeful that we'll see some increased shipments of carboplatin and cisplatin as we reach out to some other producers, particularly in Canada and Spain, to help us shore up our deficits. But we really don't know how long it's going to last.
All right, Dr. Holzberlein, thanks so much for keeping us updated. We appreciate you.
Thank you.
Thanks. All right, so we have an expert panel of urologists here to talk about all things men's health. We've got the right team here with us assembled. Okay, so we're going to start from left to right. Dr. Jake Fantas across from me specializes in men's health. Dr. AJ Nangia specializing in male fertility. And right here next to me is Dr. William Parker, urologic oncologist specialized in cancer treatment with a focus on prostate cancer. Gentlemen, thanks for being with me. How are you?
Great, thank you.
Thanks. Okay, so before we begin, we should say that some of our conversations, as you can imagine, include sexual health, sexual medicine. These can be sensitive and intimate topics, but we're not scared, are we?
Nope.
We're going to dive right in. Though when it comes to health, we want to make sure that we share accurate information and remove some of that stigma. We also encourage our live viewers to make use of these experts, so get those questions sent in, again, about all things men's health. Nothing off limits. So on that note, Dr. Nangia, why is it important? June is Men's Health Awareness Month. Why is it so important to dedicate a month to this?
Well, I think you hit it on the nail right at the beginning, is that men and women think very differently about their health care. I don't know what it is, whether it's anthropology or just socialization of our world, that men think they're indestructible, they're hunter-gatherers from the old days. They don't think about very much until it breaks. They're at maximum speed, they ignore things, and then they come back sometime later. Many times a partner or some chest pain, God forbid, triggers them, and it leads to all of the workup. But prevention is the cure, as many times. We want to be sure to encourage men to do some of their preventative care before the big one, as I call it.
The big one. So, yeah. Dr. Fantas, I want to ask you, so there's this stereotype of kind of the stoic man who doesn't really want to complain or address those health issues, as Dr. Nangia was mentioned. But do you find that to be true?
Yeah, and just to echo what Dr. Nangia said, one of the reasons our healthcare system, the way it works is that, females see their gynecologist or have somebody to go to routinely get examinations, whereas men, Dr. Nangia alluded to coming in with chest pain, but a lot of times these young men are coming to see us for health-related issues, problems with erections, infertility. Otherwise, their initial point of entry may be colonoscopy or an unfortunate cardiac event. And again, because there's nothing to pull them back in, it's very important they come back to either see us or their primary care physician.
And Dr. Nangia, you had mentioned it because if you get the screenings, then it prevents them from having to have these bigger issues. So get the screenings, and then you don't have to really sit in the office with someone like yourself. I want to ask you what you brought with us, because you are big into preventative screenings, and I want to know what kind of work you've been doing.
Absolutely. So as a total example of bad men's health myself, I didn't go to see a doctor till I was 40, whereas a good example of men's health is sitting right next to me and this side also. But I think we have to remember, although we are urologists, just like the gynecologists for the females, we are only one point, although largely genitourinary, but I think it's important for any doctor to realize that men's health is not just urological. It's not sexual, it's not the kidney, bladder, prostate type area. It's all of it. It's the cholesterol, it's the thyroid, it's the colon cancer. And I think that's why I'm so proud to show you, if I may, 2021, Governor Kelly gave us a proclamation for a month, actually, in the state of Kansas. And actually what's really, really nice in this proclamation, it spells out pretty much everything about what's important about prevention. Men live 5 years less than females. Then the list goes on to fathers. We're coming up to Father's Day, which is why this is Men's Health Week. It's Father's Day on Sunday. And so if we want to be a father, stay alive as a father, look after our family, then it's very important we take care of ourselves. But I also want to point out, since I do the infertility, that unfortunately not every male can be a father, and sometimes they have trouble becoming a father. And as much as it's celebrated, it can cause a lot of anxiety for people who have lost their father, to people who cannot have children. So I think it's a really important state of this week to remember that we are all in this together. We need to take care of ourselves as men, but also we're not just the urologists who take care of you, far from it. The internists, the family medicine doctors, the endocrinologists, the psychologists, the physical therapists, everybody who looks after a male patient is involved in preventing and treating male disease. So I think I want to point that out. And in that light, we have a men's health checklist through the American Urological Association that you can highlight and discuss with your own doctor about the different things at different stages of life, with the degree of evidence that exists in the literature, specifically like colon cancer, which has a high level of preventable state with being checked from the age of 45 onwards, to obviously hypertension, to sexually transmitted infections, to prostate cancer screening that Dr. Parker may talk about for a second.
So let's talk about that. First of all, Dr. Parker, welcome. And what do you think the secret sauce is to getting men to put their health first? The way that, you know, we encourage women to do that. Don't put yourself last, women, but we got to say the same thing to men.
Yeah, I think a lot of it is advocacy and really getting the word out there that we do need to be taking care of ourselves. Piggybacking on what Dr. Fantas and Dr. Nangia said, you know, unfortunately, a lot of times men's first experience with the healthcare system comes at some critical health event because we're not encouraged in kind of the same way for routine health maintenance. And so, you know, I think that's the first big step, is just advocacy and recognizing when a man does start to interact with the healthcare system, that may be the moment to get them plugged in with the resources, primary care, what have you, to ensure that they're getting kind of the whole care that they need.
So let's talk about prostate cancer, which is what you specialize in. The American Cancer Society estimates 1 in 8 men in the U.S. will get it, so it's pretty common, and that's why screening, as we know, is so important. When should men get screened? What does that type of screening look like?
Yeah, that's you know, generally speaking, most guidelines would say that we should start screening mid-50s through to about 70. Unfortunately, really, screening should probably begin sooner than that. I generally advocate that men start getting their PSA tested in their 40s. As we'll talk about later with BPH, or enlargement of the prostate, that influences what a man's PSA is, which is the blood test that we use to screen for prostate cancer. A simple test to help us understand the risk of cancer, unfortunately, is influenced by a disease that's very common in men as they age. getting tested earlier allows us to understand better what a man's risk is.
So is this part of an annual exam, or is this something you need to ask your doctor to perform?
So in an ideal world, it should be part of an annual exam. Unfortunately, due to some policies and things that happened kind of early in the 2000s, it is something that men need to be aware of to ask for, because not all providers are going to offer it.
So prostate cancer, thankfully, as we know, very treatable if caught early. A vast majority of patients survive, it was really good news. But what are some of the challenges of prostate cancer for those survivors? What could they expect when it comes to urology issues in the bathroom, in the bedroom? You know, what kind of issues might they be facing?
And that's a very important part of this. I will say, just to piggyback on that, screen-detected prostate cancers are generally considered curable. And so this is why screening is so incredibly important. Men do still die of prostate cancer, but typically it's the non-screen detected cancers. The issues that men have after treatment for prostate cancer are things like urinary incontinence, so difficulty holding their urine, with radiation, urinary urgency and frequencies having to go more often. Sexually, there's a huge risk of erectile dysfunction. And unfortunately, the magnitude of those impacts are largely driven by the stage at which the cancer is diagnosed. So earlier detection actually leads to less impactful lifestyle changes on treatment.
And that's the key. Again,
Correct.
It goes back to the screening equals less issues down the road. So prostate can bring issues other than cancer. What are they?
Well, there are a host of issues. So you have cancer, then there's enlargement of the prostate, like we'll talk about here in just a minute, infection, so prostatitis. There are a host of issues that can happen throughout life, but I'd say the most common are going to be prostate cancer and then enlargement of the prostate, or BPH.
So Dr. Fantas, let's talk about this BPH. What is it? And you've brought a diagram to just show us.
Yeah, perfect. So BPH, or benign prostatic hyperplasia, is just simply growth of the prostate. And, as Dr. Parker discussed, there are some cells in the prostate that are responsible for turning into cancerous ones, and there are other ones that are responsible for blocking the urinary stream, causing things like frequency, urgency, inability to empty your bladder, weak stream, needing to force to get the urine out, waking up several times a night. It can be quite bothersome to men of all ages. Now, the incidence of BPH increases with age, and while prostate cancer may affect 1 in 8 men, BPH affects up to 50% of men by the age of 50, and then almost universally affects men over the age of 70 and 80. Up to 80% of men will have some complaints of urination, likely due to some growth of their prostate.
So how do you treat it, or better yet, how do you prevent it?
Yeah, it's difficult to prevent. Your prostate grows as you age. It just depends on how much it grows and whether or not it's causing you symptoms. It's something you should obviously talk to your provider about, whether that's your primary care physician or your urologist. There are things we can do to maybe prevent it from progressing at different rates. In terms of treatment, there are lots of different treatments, ranging from simply lifestyle interventions, changing what you drink or how much you drink at what time. For example, not drinking several hours before nighttime may decrease the number of times you need to get up to use the bathroom at night. There are medications that either relax the prostate or help actually shrink the prostate. And then there are even surgical procedures to help trim the prostate in ways that allow you to urinate more easily. Those things range from the traditional Roto-Rooter procedure, or TURP, you may have heard of from your father or grandfather, all the way to newer technologies, things like the aqua ablation to kind of trim the tissue down.
Let's talk about testosterone, TRT, testosterone replacement therapy. What is it, and who's it good for?
Well, testosterone therapy is exactly what it sounds like. It is giving somebody back their testosterone. It's good for people who have what's called testosterone deficiency. Testosterone deficiency is a combination of things. It's a combination of having a low testosterone level on 2 morning tests, so we actually test how much testosterone that your body has. And it's really important that we actually have a conversation about what your symptoms are. There are a lot of symptoms that are due to low testosterone, things like problems with erections or sex drive, and then there are plenty of other symptoms that may be contributed to low testosterone, things like low energy, brain fog, some of your comorbidities. And after having a conversation with the patient, we determine whether or not you'd be somebody who would benefit from a trial. And I do mean trial because a lot of times people don't benefit and we stop it.
Dr. Nangia?
And I think it's important, Dr. Fantas and I and others, comes back to men's health. All right? There are some specific symptoms, and they're not very specific, to do with low testosterone, the sexual medical type symptoms. The ones that are very generic and multifactorial is the brain fog, the low energy, the ability to concentrate. And I'm like, welcome to the 21st century. and not sleeping well, obesity, sleep apnea, and the list goes on. And people focus so heavily on the testosterone being the be-all and end-all of their problem, and it isn't. It's their overall health, weight loss, diet, sleep, exercise, but not only that, but then stress. Goodness knows we know that stress can cause all sorts of general medical health issues. But we forget those and they latch onto testosterone. One other thing I just want to point out, I know Dr. Fantas would agree with me, is when you said not to use testosterone. And that is in men who still want children. Let me say that again. Men who still want children. Because testosterone actually shuts down the ability to make sperm. Just like female birth control pill or others, the hormone that stops the female cycle, menstrual cycle. Men are way too often put on testosterone when they still want children. So we have to stop it, they get upset with us, we have to give alternatives, and it can all be prevented by not having been put on testosterone in the first place. And ever since 2000 and onwards, unfortunately, the testosterone industry has become a multi-billion-dollar industry with men's health clinics. And that's fine, but to a degree, right? It has to be worked up properly. The other medical conditions need to be evaluated, such as the thyroid. The list goes on. And so I think that's very important to remember that testosterone is not the be-all and end-all on men's health.
And Dr. Nangia, I want to stay with you on that, because let's talk about birth control. Women often seem like a lot of that burden's on them. If couples are family planning post-children. So let's talk about, will there ever be more options for men to take that responsibility in a couple, between a couple?
That's a great question. So as you know, for now nearly 60, 70 years, the onus has been on the female ever since the birth control pill and other methods came out. And the men have for centuries really only relied on, dare I call it, the condom for reversible, and then of course for permanent status, a vasectomy. And that's all we had. There are a couple of others, withdrawal, abstinence, type of things that men can control. But with the recent political climate where women's reproductive rights have been addressed, and I'm not going to get political, I just want to point that out, we've noticed a massive increase in consultations for vasectomies. So men are now stepping up to the plate in a different way, but there are many of them who have already completed their families, just haven't got their finger out and decided to get it done, and now the onus has been to get it done. And that's what we've noticed, a really rapid increase since last September or so on men wanting vasectomy, sometimes as high as 2 to 3 to, even in the community, 900 times higher, 900 times. But in that light, what has also come out has been a greater onus on the research, as you said, on trying to have other methods, such as, ironically, testosterone and a mixture with another hormone that we use in females called progesterone. And we're actually just part of a National Institute of Health contract trial that was using it specifically as a contraceptive, despite what I just said about don't use it. That's fine, but it's on a trial, and it will eventually may have an indication for its use as a preventable, as a reversible form of contraception.
Dr. Nangia, I want to get your thoughts on something. We have somebody in our office who tried to get a vasectomy, but their doctor refused to do it because they did not have children. They are an adult. They already know they do not want children. They are in childbearing age. What is up with that?
So this is where we even have some dilemma in amongst ourselves. And truthfully, if you are under the age of 30 and childless, not having any children, you are 12.5 times more likely to want it undone than if a man had his vasectomy over the age of 30. So maturity of decision making is unfortunately somewhat a little bit sometimes paternalistic of a physician, but we also have to be respectful of the patient's situation and what they're leading to as to why they want a vasectomy while being having no children.
Because you're thinking that maybe they're doing it for birth control purposes?
So that's coming up now.
Okay.
And that has happened. I now had at least half a dozen patients who know that they want children in the future and want a vasectomy, and then my heart gets a little bit tight because I'm like, we view that as permanent. Even though we reverse them for people who have changed their mind or had, God forbid, a death of a child or divorce, which is the most common. But now we are physically being asked to know that up front that they might want children, and is it ethical to do that? Right? That's just one, right? That's just based on that, and based on how old a patient is, maturity, how do we judge that? Because legally they could have a vasectomy from the age of 18.
That's a real
And that becomes really hard. And I will tell you what I tell my patients. That's when I do get a little bit paternalistic, and I tell them that that's my moral duty, not my ethical duty, because I'm a dad. Right? And this is where it becomes very tricky for me with a young male son who may not be quite ready and has already even mentioned, I don't want kids, Dad. And I'm like, all right, the next minute he does.
Right.
And that change of where the vasectomy is now considered reversible is becoming a real dilemma.
It is. My husband had a vasectomy through a first marriage, and then found me, and now we have 2 children. Had to have it reversed, but it didn't work. So then you have to go down the IVF.
Right. Right, and so
it's very, very difficult.
It's usually a decision that is made not about being reversible, ironically. We think about it as, what if the sky falls? Then something drastic happens. Unfortunately, divorce is very common, so that's becoming obviously more common to see people. But I think it's
key to say that the reversal is not, it's not an easy, it is not an easy thing. It's very pricey. It is definitely not for
100%.
sure. I see your head shaking quite a bit. Jump on in. What are your thoughts just about everything we've been discussing and men fertility?
Well, I mean, I think piggybacking on what Dr. Naggia said, it really, the challenge is that this is something that we do view as permanent, and it's hard to balance that. You know, the fact that we do have this ability to reverse it, because in theory that makes it seem like it's not a permanent, because we have the ability, but it comes down to that idea of just because we can doesn't mean we should.
That's right.
And that's where the real challenge and the kind of patient decision making and the shared decision making has to come in.
And it's tough, and Dr. Fantas, you know that. I mean, times have changed. Not everybody wants children. I mean, I probably have 5 girlfriends who do not have children and do not want children, and they never did want children, not because they couldn't have them or because they didn't get married, it's because they didn't want kids. So it's tough because the generations have changed. Do you agree, disagree?
I completely agree. I think that what Dr. Naggia said is incredibly important. We both see quite a few men for vasectomies, and just getting someone's thought process is really important. If they're with a partner, oftentimes I actually examine them with the partner out of the room and make sure that this is something they want to do for themselves. There's a really good paper published not that long ago looking at what's called vasectomy regret. And what we found is that it's not necessarily men without children that regret vasectomy, but men that feel like they were talked into getting a vasectomy. So I think it's really important for all those men out there to make sure that you're making the decision, obviously for you as a couple, but also you as yourself.
Really good point. Be sure to ask your questions. You can use the chat on YouTube or Facebook. You can tweet us, email the Medical News Network. It's right there on your screen. Let's get our COVID count from Dr. Dana Hawkinson. Good morning.
Hi.
How are you?
Good. Such a good topic.
Good. I know. Jump on in anytime.
Men's health, but I think also just global men's health, just to Dr. Naggia's point, it's also, would be remiss if we didn't talk about vaccines, so important to stay up on that, as well as all of the other screening that we've talked about as well. So right now here at the health system, talking about COVID now, we have 14 total, but only 5 active cases, 0 in the ICU and 0 on the ventilator as well.
So let's talk RSV. We mentioned the new vaccine for adults before, but now there's the new treatment coming for infants and toddlers. That's pretty big news, right?
Yeah, this is really good. Again, RSV is a virus that affects the respiratory system, so basically your lungs. It is a disease of the very, very young and the very old. This is news about a new injection, a monoclonal antibody that they would give to infants in their first RSV season, whether they're born in the late fall or the winter, to help protect them against the severe disease caused by RSV. So we are making really good headway on prevention and treatment of RSV. This is one of those things as well, again, to protect those most at risk.
All right, Doc Hawk, thanks so much. Any reporters with us today? Let's get to our community questions. And Aaron wants to know, Dr. Fantas, can you just touch a little bit on erectile dysfunction? We know there's treatments like Viagra. Is there other treatments, prevention, and just what causes it?
Yeah, that's a great question. I think the big thing with erectile dysfunction causes are that often they're multifactorial, meaning several different things can cause them. From just aging and hardening of the arteries, comorbidities, which are the big one, things like high blood pressure, high cholesterol, diabetes, obesity. Those things can cause damage to the blood vessels and nerves, which are intimately important for erectile function. And then there's probably something a lot of you have heard of called performance anxiety or psychogenic erectile dysfunction. And the reason this is really important is that some of these causes can easily be treated with oral medications, others can't. And it's also important to note that if somebody has a bad experience, it's possible that their erectile dysfunction is caused by more than one thing. Maybe it's caused by their high blood pressure, the medication that actually is used to treat high blood pressure, and because they've had bad experiences, performance anxiety. So it's very important to kind of parse these things out. In terms of treatment, you're right. The number one treatment in concert with this Men's Health Month would be lifestyle modifications, including weight loss, diet and exercise where appropriate, as well as treating those comorbidities I just mentioned. Men that are able to treat those comorbidities, again, high blood pressure, cholesterol, diabetes, and lose weight up to 10% of their current weight, often will have some reversal of symptoms such as improvements in their testosterone level and even in their erection. So I would say that is the first step, and I talk to any man who qualifies to do that first. After that, you're right. There are pills like tadalafil, Cialis, and then sildenafil or Viagra. There are a few other pills on the market. There are also other things that are more invasive, like injections that go into the penis, pellets that go into the penis. There are even vacuum devices. There's even a surgery we can perform that actually corrects erectile dysfunction by replacing your natural erectile tissue.
All right, question for Dr. Parker. What are the weirdest questions that you get out and about? I don't know, dinner parties, cocktail parties, friends text you, in office. What are some just randoms?
They all begin with, I have a friend.
Of course, asking for a friend.
Asking for a friend, I'm asking for a friend. I think probably the most common questions I get asked out and about either have to do with erectile dysfunction or more commonly urinary issues. I would say, piggybacking back to the BPH conversation that Dr. Fantas had, enlargement of the prostate is such a common condition. I have people come to me all the time, start to either ask for the friend or sometimes ask for themselves about, how do I make this better? How do I improve my flow? Getting up all night long. So that's typically what it is.
Well, at least they're asking.
They're asking.
So that's good.
It is.
That's good. Okay, so let's talk testicles. I'm looking at you, Dr. Nangia.
Well, I don't know how that happens, but it always seems to happen. It just does.
You're the testicle guy. Tell us how we're doing self-exams. Give people the specifics, make them feel comfortable about doing it, and how often they should be doing it.
Yes. So this is actually a soapbox issue for me. Again, I have a young male son, and therefore it's most common cancer of young adult males from 15 to around about 35, 40 is actually testicular cancer. 15,000 plus cases a year. It doesn't sound like a lot, but it is this solid tumor number one cause. But in that light, it's largely a concern where rapidly producing cells, both for sperm, can go wrong, and so germ cell tumors, they're called, can develop. They can be very rapidly growing, and so catching it relatively early has been the mainstay. Now, that statement is actually not actually easy to answer. How do you catch it early? One would argue self-exams, like catching breast cancer through breast exams, but sometimes you might catch it late, and therefore teaching self-exams actually has been somewhat controversial. The United States Preventative Services Task Force that looks at the evidence that a lot of our screening is based on actually does not recommend it be done. They actually don't recommend breast exams be done. So how do you take something that you should be doing to yourself, arguably, which is free, being aware of your own body, both your breasts and males, by the way, not just female, but male breasts, 1% risk of cancer in male breasts. But testicular self-exams is, once you teach a young man to do it and how to do it and what the right way to do it, you don't get a lot of anxiety. You hopefully get a lot of education because it's the false positives, we call it, that lead to people coming in.
You don't want people relying on the test.
Not relying on the test or freaking out that they found something that ended up being normal. And one of the arguments the USPSTF says is that the psychological consequences outweigh the actual curability of the disease. Now, all three of us here have looked after people who have become infertile, who've lost a testicle, who've had disease in their abdomen, and you can't tell us that that's okay, right? They end up getting the chemotherapy that Dr. Holzbein was talking about, right? That's not easy. They get more surgery on top of that. It can cause ejaculatory dysfunction. It can cause later issues with, of course, having children unless they threw a sperm ahead of time. So you're talking to the wrong passionate group about the down the road problem. right? Prevention is doable. Now, agreed, we may not catch it early, but at least we want to catch it as early as possible.
Dr. Parker, anything to add?
Well, I would just piggyback on that. I think, testicular self-exam is easy. You should be doing it. You should be feeling your testicles in the shower, take a feel, see what things feel like. But the most important thing is really just not being afraid of what you feel, seeking the advice, seeking the evaluation. Often we find that men tend to hold this to themselves. They're afraid of getting an exam. They're afraid of what the outcome may be. And then, to Dr. Nangia's point, they show up later in the disease process. And while it's incredibly curable, just the treatments have to be escalated to achieve that cure, which means the side effects increase, the quality of life impacts increase, and that can all be mitigated by finding it earlier.
All right, we're running out of time, but I want to get a couple more questions in really quick. Jerry says he's heard of the term turn your head and cough test, but has actually never had it done by a doctor. Is that even a thing, Dr. Fantas?
Yeah, it's absolutely a thing. It has less to do with testicular exams. It's more to look for a hernia. But as again, Men's Health Month, one of the common complaints, and if you go to Dr. Nangia's screening thing, it talks about having genital urinary pain or pain in the scrotum, and that's something that's incredibly important to rule out as a source of discomfort. Would be one of your abdominal organs kind of making its way down to your scrotum and causing pain.
Some of the things that we've been talking about as we age, is that what male menopause would be considered? Olivia wants to know.
Well, male menopause, often, as I think about it as a prostate cancer treatment person, we give medicines to block testosterone. That's typically the loss of testosterone is what we refer to as menopause or male menopause. And it does have a similar spectrum of symptoms, hot flashes, fatigue, the brain fog, all the things that we expect with what we see in loss of estrogen in women. Certainly, I induce it as part of a treatment, but that is what we're referring to.
All right, we're going to get our takeaways today. Dr. Fantas, I'm going to start with you, and if you wouldn't mind answering Jeremy's question. He just wants to know, beyond just regular prostate checks for men, is there anything that they should be asking in their routine appointment that maybe they just aren't asking or should be?
Asking their physician? Or
asking a physician, diving into, checking up on.
Yeah, I think it's really important, again, to make sure that they're addressing everything from depressive symptoms, sleep problems, erections, urinary symptoms. We just talked a little bit about scrotal pain as well. I would make sure that you endorse anything to your physician. If you're having something bother you, some new symptom that you're not aware of, if you're not sure it's normal, that is what we are here for, to detect the difference between normal and abnormal, kind of piggybacking on what Dr. Parker was talking about with the self-exams. If you notice something, I think it's really important to bring it up. Maybe it is normal, but I think it's important for you to know it's normal, to have some peace of mind with your own body.
Right. Great takeaway today. Dr. Nangia?
The main takeaway is that it's about taking care of yourself. You're the first and most important person who's going to seek help until you break, so please don't break. I want to wish you all a happy Father's Day, and to those who have lost their fathers, may they be in heaven and looking down upon you and your families. And those who are having trouble being fathers, please seek help. We're here for you. And don't feel like it's a stigma or something against your manhood. It's a couple's issue. We are here to help you.
Thanks, Dr. Nangia. Dr. Parker, what's the takeaway today?
For me, certainly prostate cancer is a very common disease. Please be screened. Please ask for screening. It's incredibly curable. And just remember, there's this myth out there that you die with prostate cancer, not from it. Prostate cancer kills a lot of men every year, and that's a potentially avoidable outcome with early detection and screening. So please get your PSA checked, and unfortunately a digital rectal exam.
Unfortunately. Thanks for adding that in there. Gentlemen, thank you so much for being with us today. We'll be back here at the table next year, like we do every time. Every year.
Thank
all
you.
Right. Thanks to all of our viewers today. Great questions. We'll see you back here Wednesday. Coming up Wednesday on Open Mics with Dr. Stites. 1 in 8 men in the U.S. will get prostate cancer. Sometimes a common disease requires an uncommon treatment. I'm Jessica Lovell on the next Open Mics with Dr. Stites. We ask when patients should seek out proton therapy for their prostate cancer and the benefits of a complex surgery more men with prostate cancer are seeking. Wednesday at 8.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.